All right, welcome everyone. This is the Neurotology Eastern Region Virtual Education Series. And today we have Dr. Brent Wilkerson from the University of South Carolina School of Medicine at Greeneville, who'll be talking about the treatment of complex BPPV. Super lucky to have you, and thanks so much for volunteering to do this. I hope that this continues to grow, and it's only because of contributions from the entire community that it'll eventually become a big success. So with that, I will turn it over to you.
Well, thank you, Dr. Raymond. And being now in Greeneville and kind of on my own without other neurotologists around me in the same practice anyway, this lecture series has been very helpful to me. I found it very helpful to kind of keep up with things, and so I wanted to contribute, and hopefully I can contribute something beneficial here. So I wanted to talk about the treatment of complex BPPV, and so we'll get kind of started with some of the history first. So BPPV, we're all familiar with that, but it was first described, kind of a clinical presentation by Dr. Barony in 1921. And then Dixon Hallpike evaluated some histological evidence that showed utricular macular degeneration. And they actually coined the term benign paroxysmal positional vertigo in 1952. Shuckneck described cupular deposits, and he proposed that loose otoconia from a degenerating utricular macula floated in the region of the cupula and caused displacement, and coined the term cupulolithiasis. And then in '79, Hall and colleagues kind of married both canalolithiasis, where the otoconia were in the canal, and cupulolithiasis, both contributed, and so they coined the term canalolithiasis in addition to what was already described by Dr. Shuckneck in cupulolithiasis in the 60s. And then Parnes and McClure were the first to demonstrate this in vivo. And so we know that there are these principles, and these principles are really important when we're talking about and thinking about physical exam findings regarding what the otoconia are doing, what the endolymph is doing, and what's being stimulated, and what are the eye movements. And so these principles are really important. And so even though we've heard them many times and I go over them, they're fairly simple. So Ewell's first law is that the stimulation of the semicircular canal causes movement of the eyes in the plane of the stimulated canal. Makes sense. Second law is in the horizontal semicircular canal, ampulopedal endolymph movement causes a greater stimulation than ampulofugal one. And so we'll go over those terms again, ampulopedal and ampulofugal, before we kind of get into physical exam findings. Then the third law is that in the vertical semicircular canals, so the posterior and superior canals, the reverse is true. And so when we look at ampulopedal, ampulofugal, ampuloPedal means towards the ampulla, whereas ampulofugal means away from the ampulla. So let me just get my little laser pointer here. And so when we're thinking about the ampulla, the cupula, and the stereocilia that are in the ampulla, stereocilia, when they're deflected towards the tallest stereocilium, which is the kinocilium, it activates, releases those channels and causes activation, and the vestibular nerves activated. In the horizontal canal, the kinocilium is oriented closest to the utricle, thus Ewell's second law. And so if we make this our horizontal canal, the kinocilium would be oriented here, closest to the utricular side. If in the posterior and superior semicircular canal, it would be here. So it makes sense that in the horizontal semicircular canal, you have ampulopedal movement, so movement towards the ampulla of the endolymph causes deflection of that kinocilium this way, of course, because ampulopedal, and that causes activation. Whereas in the superior and posterior, it's the opposite. So ampulofugal causes increased stimulation because they're being deflected towards that kinocilium on that side. So this is our representation of the posterior semicircular canal. And head rotation, if you're rotating your head towards the left, you kind of think of the membranous labyrinth moving and the endolymph essentially staying still, but there's relative motion towards the opposite side. So head rotation towards the left, endolymph movement relatively moves towards the contralateral side. And so in this case, you have ambulopedal flow. And of course, the kinocilium in the posterior canal is more in this location. So it's being deflected away, so decreased neural firing. Whereas in ambulofugal, head rotation on the contralateral side, or to the right side, you have ambulofugal movement and therefore it's increased neural firing rate. So then we got to talk about the vestibulo-ocular reflex. So in the membranous labyrinth, when it moves, like we just talked about, head movement occurs, endolymph doesn't, whereas the membranous labyrinth does move with the head movement. And so relative motion. So in this case, you have head motion towards the right, and this is the horizontal canal that we're depicting here. So the heads move towards the right, the ambulopedal flow occurs, which increases firing rate. Increased firing rate then stimulates cranial nerve 3 via secondary vestibular neurons and cranial nerve 6 on the contralateral side. So we're stabilizing gaze towards the left side. And so that's why our eyes can turn to the left when our head is turning to the right. So that leads directly into the caloric principle. And so in this case, when we do calorics, when we're looking at VNGs and looking at the caloric results in VNGs, this is what they're doing. I'm sure you're all familiar with this, but when warm water or warm air is inserted into the ear canal, it changes the temperature of the lateral part of the horizontal semicircular canal and thus its density. And when it does that, and the lymph, if warm air is infiltrated or warm water is infiltrated, becomes less dense or lighter, and so ambulopedal flow occurs there. And in that case, ambulopedal flow, it's activated. So you can think of the eyes being moved towards the left side, the slow phase, but we're mainly watching for the fast phase of nystagmus because that's what we're going to identify. And so fast phase is going to be towards that side. Thus, cold opposite, warm the same. Cold, you're going to make this more dense in the horizontal canal, and therefore you can kind of think of it as falling away. And then when that falls away, ambulofugal flow occurs, and so the fast phase is going to be opposite. So that's the Cowles mnemonic: cold opposite, warm the same. And so those are our principles that we're going to utilize in seeing what physical exam findings we're going to see, what kind of nystagmus we're going to see when we perform these maneuvers, and so we can diagnose exactly which canal it is and best how to treat our patients. So BPPV is, of course, the most common cause of vertigo seen by otolaryngologists, and it represents 17 to 40% of patients with peripheral vestibular disease. Of course, the mean age of onset is in the 4th or 5th decade, but it can occur in any age and can occur in childhood. There may be some type of migraine-induced ischemia that can occur. Theories are positive regarding that. And then the incidence increases with age. So the typical history we are all familiar with: vertigo with change in head position, whether they're rolling over to one side, whether they're bending over and then rising from that bending position, whether they're looking up or reaching for something, whether they went to the hairdresser and got their hair done and got vertigo when they did that, or went in the dentist chair. A specific side can be frequently volunteered as well, and symptoms typically occur fairly suddenly. They last briefly. It can occur in time, and then you have clusters where you're having a lot of episodes and then not having it for months. And see a lot of these patients who also have these kind of secondary subjective symptoms that not necessarily you would associate with classic BPPV symptoms, but the subjective dizziness, imbalance, lightheadedness, feeling like things are off, even brain fog, almost like migraine symptoms for some of these patients. And it can be associated secondarily with head trauma or viral labyrinthitis, Meniere's disease, migraines, inner ear surgery. And so those are all things that we can think about when evaluating the etiology in these cases. So let's get into the physical exam findings. So we're going to first start with the posterior canal. It's the most common. 85 to 95% of cases are going to be posterior canal BPPV. So let's think about laying someone down on the right side, so performing either a side lying test on the right or a right Dix Hallpike. And if it's positive, what kind of nystagmus are we going to look for? And the classic nystagmus is for posterior canal BPPV. What you're going to see is torsional right upbeating nystagmus. And that would indicate, in this case, right posterior canal canalithiasis. And how do we treat that? Well, we treat it with the Epley maneuver or the right Semont maneuver, which I'll talk about, which may be a little less known, but give us a couple of options on the treat patient if they don't respond to one, or if you prefer one or the other. So here's a little video. So these videos here are courtesy of Dr. Sargent from Michigan Ear Institute. And so we had a Omniax, a positioning chair that allowed these maneuvers, particularly useful in patients who had kyphosis or immobility. And so this, we're looking at the right Dix Hallpike position. And so we're going to see the results of what a right posterior canal BPPV would show. So you're going to see the patient laid back, or representation of the patient laid back to the right Dix Hallpike position. And we're going to see torsional, so slight rotational component, and it's upbeating and beating towards that right side. So you could say geotropic torsional nystagmus, upbeating nystagmus, which would be representative of a right posterior canal BPPV. And now undergoing the Epley maneuver. And we're going to see another video of the eyes here shortly. So now position 4 with the Epley. And again, geotropic torsional upbeating nystagmus. So those crystals or those otoconia are traveling in that same direction, which is why we're going to see that same geotropic torsional upbeating nystagmus for posterior canal BPPV. And we're all familiar with the Epley maneuver, but again, it starts in position 1. You lay back with starting with the Dix Hallpike, so Dix Hallpike head hanging position towards the right if we're treating the right posterior canal. And this is in 1 to 2 minutes. You lay in this position here, turn 90 degrees to the contralateral side, and then another roll of 90 degrees and keep this position for 90 minutes here, and then sitting up with your with the chin tucked. And that's the Epley maneuver, and it's quite effective. So for posterior canal BPPV, it's been several studies that we've seen that clearly this is an effective maneuver for these patients, and the one we do the most. It's 6.5 times greater in the Hilton study than in controls. Greater chance of improvement 6.5 times compared to controls. And the Amar Dorado study looked at Dix Hallpike versus the Brent Deerhoff, and it was by day 7, 80% effective or negative in those cases versus 25% if just the Brent Deerhoff were done. And then also looking at the canal repositioning maneuver versus sham, 91% versus 46. So quite effective. But there's another option. You can utilize the Semont maneuver as well, or the liberatory maneuver. And so this is a representation of that. And this is treating right posterior canal BPPV as well. So we'll just let this video play here.
This is the liberatory maneuver, also known as the Semont maneuver, for treatment of right posterior canal BPPV. Perform this maneuver under direction of your physical therapist or physician after BPPV has been positively identified to be affecting your right posterior canal. Sit on the edge of your bed and turn your head 45 degrees to the left. Then quickly lay down on your right side. Stay in this position for 1 minute. Then quickly go from laying on your right side over to your left side. Do not change the orientation of your head, so you should be looking diagonally downward when you are laying on your left side. Stay in this position for 1 minute. Slowly return to sitting and sit on the edge of your bed with your head level for 10 minutes.
All right, so that's the Semont Maneuver, which you can utilize for posterior canal BPPV. And so it's also quite effective in studies. Levrat et al. Looked at 278 patients, were treated weekly for 4 weeks, divided into several categories, including traumatic, infectious, idiopathic, miscellaneous. And the resolution after one maneuver was 63% effective, after two, 84%, and after four, 90%. Some of the failures that can occur or posited to be the reason for failures, duration of symptoms being greater than 6 months. So in those cases, it was less successful. And then traumatic category had one of the poorest outcomes after one treatment as well. So those things may impact how well they respond to the Semont maneuver or the Epley maneuver. So if you think about posterior canal and the superior canal on the contralateral side, referred to as being coplanar, so they're roughly in the same plane. And so you can kind of imagine what the nystagmus or the physical exam findings would be for superior canal BPPV. So for this example, and this is a much less common etiology for BPPV, 1 to 11%. I have not seen it often. I have seen it a couple of times. So in this case, we're going to utilize the left Dix-Hallpike maneuver. And so we're going to test this patient. If it's positive, and we're looking for what the result would be if they have torsional right downbeating nystagmus. So essentially the opposite of what you would expect for if this patient had left-sided posterior canal BPPV. In this case, if they had torsional right downbeating nystagmus, that would be right superior canal canalithiasis. And so there are several ways to treat that. I'm going to show a little video here in just a second. In this case, you can do the left Epley and have generally effective resolution, but there are a couple of other options. So if you do a Dix-Hallpike and the patient has BPPV and it's not quite clear on what nystagmus is doing, because sometimes it can be quite subtle about whether there's upbeating or downbeating nystagmus, not always as clear as the first example. If you perform a Epley maneuver, you may get significant benefit even if it's the right superior canal, and so that's an option to do that, and it can be effective. And then there are a couple other options like the reverse left Semont and the deep Dix-Hallpike. So having a couple more maneuvers in your armamentarium is not a bad idea for these BPPV cases that may be a bit more complex or a little atypical. So this would be right superior canal BPPV. So we're starting in the left Hallpike maneuver. And so we're going to see torsional downbeating nystagmus towards the contralateral side. So right torsional downbeating nystagmus, and this is fairly subtle. So a small torsional component, you can see the downbeating component there, but with my naked eyes, I probably wouldn't be able to distinguish that very well. With Frenzels, it'd be a little bit better, but utilizing this and being able to see it over and over again, then you can kind of tell. But we don't have that generally. Most people have that don't have that in their clinic to see. So that's right superior canal BPPV. So you would expect downbeating torsional nystagmus towards the opposite side. So the reverse Semont is another option. So the Epley maneuver on the side that you perform the Dix-Hallpike, and that's positive. You can do that. You can also do the reverse Semont. The reverse Semont is head nose down. So the position would be 1 first, and so this would be for left-sided superior canal BPPV. And so you nose down to the affected side in this case. So position 1, position 2 would be nose down, 1 to 2 minutes, and then quickly head up position toward the contralateral side. And position 3, 1 to 2 minutes, and then sit back up. The other option is the deep Dix-Hallpike, and this would represent right superior canal BPPV. And so head turn to the left, deep Dix-Hallpike for 1 to 2 minutes, and then sit back up. So those are some options for the deep Dix-Hallpike. This is a graphic from our Academy's BPPV clinical practice guidelines. And so as we get into horizontal canal, I just wanted to kind of bring it up, and we'll look at it again here as we get towards the end. But this is the beginning here. So we can kind of go through this. Patients who have a history or symptoms consistent with BPPV, you want to, of course, differentiate BPPV from other causes. And then if they are consistent with what you think BPPV is, you're going to perform the Dixell-type maneuver. If it's torsional upbeating nystagmus, then posterior canal. If it's torsional downbeating, it could be superior canal, which is not indicated here, but you can kind of move on. However, if it's not torsional upbeating, more horizontal, then we're going to move into the horizontal canal BPPV. So that's what we're going to get into now. So horizontal canal BPPV, it's reported as less than 5%. Some reports as high as 30% may be horizontal canal BPPV. And there are two types. The geotropic is much more common than the apogeotropic. Geotropic has the otoconia that are situated in the posterior segment of the lateral canal, so canalithiasis. And more intense nystagmus occurs when head is turned to the affected ear. And then apogeotropic either has otoconia attached to the cupula or within the anterior arm of the horizontal canal near the cupula, and more intense when the head is turned towards the healthy ear. So geotropic horizontal BPPV and geotropic horizontal nystagmus, if we see here, is represented in the right side. This would be that geotropic form. And so you have the otoliths in the kind of the posterior part of the horizontal canal. And so when the head is turned towards the right, remember ambulopedal flow causes increased stimulation. We're going to see the fast phase beating towards that affected ear. And then if we rotate the opposite side, so a supine roll test, you turn the head to the other side. You're not turning the shoulders in this, but we'll see that in a second. You turn your head to the opposite side, you're going to have a decrease in stimulation because you have ampulofugal flow with geotropic. The eyes are still going to be beating towards the side that's down, but it's going to be less intense. And so you have direction changing nystagmus. In apogeotropic, you also have direction changing. However, the cupula, of course, is here. Otoconia are more in the anterior part or next to or attached to the cupula. And so when you turn towards the left, you get ambulopedal flow. And with increases, the fast phase is going to be towards that affected ear there. And then moving towards the opposite side, ampulofugal with the otoconia moving away from the cupula. And you're going to have direction changing. But the fast phase is going to be away from, so it's going to be apogeotropic. It's not going to be geotropic. So when you think about what is, which sides is on, is it right canalithiasis, is it cupulolithiasis? Think about the intensity of the nystagmus. So think about the intensity. What side is it stronger on? And then is it apogeotropic or geotropic? So if it's stronger on the left side and it's an apogeotropic, it's going to be right cupulolithiasis. So if it's geotropic and stronger on the left side, it's going to be left canalithiasis. However, if it's stronger on the right side, right canalithiasis. If it's geotropic, apogeotropic, going to be left cupulolithiasis. So stronger, what side is stronger, and is it apogeotropic or geotropic? So this is left horizontal canal BPPV. And so let's play this video. We're going to see some nystagmus here. Is laid supine. We're going to see some right beating horizontal nystagmus, but as we turn to the left, we're going to see, I believe, geotropic horizontal canal BPPV and geotropic horizontal nystagmus. So left side lying test now, and it should be more intense. All right, some latency there, and then now you see some left geotropic horizontal nystagmus. A little bit of a downbeating component, but predominantly horizontal. So this would be consistent with a left canalithiasis of the horizontal canal. And then we have the supine roll test. Here's another video showing right horizontal canal BPPV. Again, this is geotropic.
Eyes are beating to the left.
And I'm just going to fast forward just a little bit here.
I'm going to turn your head to the right now.
All right. So geotropic towards the right
On
side.
the right, you have some dizziness. That's quite strong, and to the right. Did it feel stronger to you? Yes. Okay. All right, I'm going to turn your head all the way to the right. Because we're going to do something called the supine roll test. Its dizziness is stopped now. And now we're going to turn your head all the way to the left. Go ahead and turn it. That's good. And let's see what we get. There's a long latency. And here comes a left-sided response. But not very long lasting and not as strong.
Okay, so you can see in that video the fairly strong or more intense geotropic nystagmus, horizontal nystagmus towards the right side. However, when turning towards the left side, had direction changing, so it was still geotropic on that left side, but it was much less intense. So how can we treat horizontal canal BPPV? And we have several maneuvers in our toolbox that we can utilize. And so those include angular accelerations, the slow gravitational or sedimentation, prolonged positioning or the Vannucci maneuver, and then sudden linear accelerations with the Gufoni maneuver. So the Gufoni maneuver, this is representative of how you would treat a geotropic right horizontal canal BPPV. So geotropic versus apogeotropic is slightly different. And so in this case, we would be treating a right horizontal canal BPPV. So position 1, let me get my little laser pointer here again. So position 1 here, and then you lie down quickly to the unaffected side. So the unaffected side first, 1 to 2 minutes, and then after 1 to 2 minutes and the nystagmus has subsided, head is quickly turned 45 degrees towards the floor. So here, and so think about if this is right-sided again, and this is geotropic canalithiasis of the horizontal canal. And as the head is turned towards that left side, think about those otoliths traveling in this direction towards the utricle. And then as the head is turned down, it continues its course there. And then the patient sits up after head is turned down 45 degrees for 1 to 2 minutes. And for apogeotropic, it's slightly different. So you're going to quickly lie down to the affected side and 1 to 2 minutes. And then after 1 to 2 minutes, head is quickly turned up towards the ceiling, 45 degrees, held for 2 minutes. And so this video quickly shows that. They don't hold it for 1 to 2 minutes, but that's what you would do in the clinic. And then rotating 45 degrees to the left. And so that's for apogeotropic horizontal canal BPPV, and that would be treating the right side there. And then you have the Limpert rotation or the barbecue rotation, and this would be treating right horizontal canal BPPV as well. And so let me just show you this video, and I'm gonna fast forward a little bit here. If I can. All right, let's go a little bit further here.
Sit on your bed with your legs outstretched in front of you, and then slowly lay down on your back. Roll onto your right side and wait for 30 seconds. While your head remains in contact with your pillow, slowly roll onto your back and again wait for 30 seconds. While your head remains in contact with the pillow, roll to your left side and wait for 30 seconds. Gently tuck your chin towards your chest Roll onto your stomach, propped on your elbows. Wait for 30 seconds. Then gently tuck your right elbow underneath your body, rolling back to your right side, keeping your head level, and wait for 30 seconds. From there, return to sitting at the edge of your bed, slowly.
All right, so that's the barbecue rotation or the limpet rotation for right horizontal canal. I've included these little graphics down here just because it's helpful, at least for me, to kind of identify where those otoconia are traveling and why these maneuvers are effective. The Vannucci maneuver is forced prolonged positioning, so the patient lies on the unaffected side down for approximately 12 hours, so easy enough to do if they can lie down for that long and not move around too much or at all. The treatment outcomes in these cases, so Gufoni looked at 147 patients who had both geotropic and apogeotropic horizontal canal BPPV, and of course geotropic was more common, as it is, compared the limpet rotation to plus the Vannucci maneuver versus the Gufoni maneuver, and success after one session was 61% for the limpet Vannucci versus Gufoni at 86%, and then at 1 month, looking at both are quite effective, 81% for the limpet and Vannucci, and 93% for the Gufoni maneuver. Another looked at 60 patients, Taurus looked at 60 patients with canalithiasis, and 13 were treated with the barbecue rotation with only 38% success, 29 with the Vannucci with 89%, and then 18 with Gufoni with also very reasonably effective, 76%. So horizontal canal BPPV kind of conclusions there. Remember the geotropic and apogeotropic. You diagnose which side it is based upon the intensity and whether it's geotropic and apogeotropic. So that can help you be effective in treating it based upon the knowledge of whether it's where it's at, which canal it's at, and which maneuvers can be beneficial in resolving it. So a couple of special cases or special interesting things that most of us have seen in clinic. So we have this phenomena of the subjective BPPV, where a patient comes in, they describes exactly what you would expect for BPPV. When I lie down or when I turn over, I get vertigo. It lasts for a few seconds, goes away. It only occurs when I move or if I bend down. But when you perform the Dix-Hallpike as you would, they don't have, even though they experience the classic vertigo symptoms, they don't have the physical exam findings. So they don't have nystagmus as you would expect. And so even in those cases, in my training, I was always trained to perform the pre-positioning maneuver. And so I do in those cases. If their symptoms tend to be classic, you lay them down, there's a little bit of latency, then they have vertigo or describing vertigo for several seconds, and then it resolves. I tend to put those patients through the epley or the repositioning maneuver in those cases. And various studies have found that it's effective in up to 76 to 93% of cases. And some theories about that is, well, we've seen subtle nystagmus on one of these videos at least, and we certainly see it in our clinics fairly frequently, where it's fairly subtle. You may not quite get it. If you use Frenzels, it may be a little bit better. But even then can be quite subtle sometimes. Fatigue nystagmus from repeat testing can occur, and then maybe there's a theory about the less noxious form that elicits vertigo but doesn't actually stimulate the VOR pathway. And so those cases I typically put the patient through the epley maneuver or the repositioning maneuver. The other things that may affect positioning maneuvers, well, I wouldn't say controversy but opinions about whether to do it multiple times in a single session versus just a single epley maneuver or repositioning maneuver. There's no consensus, I would say, on that. The argument against doing multiple would be if there's a fatigue response, how do you know it's just not a fatigue response versus a complete resolution? And then skull vibration, Lee et al. Looked at, found that there was significant more success, 92% versus 60% who didn't have the skull vibration. And then various studies have not corroborated that since then. And so Hain was one of those that looked at this and found that there was this overall 78% effect or success without any difference between utilizing vibration during the repositioning maneuvers versus no vibration. And then post-maneuver instructions. I personally have still been doing it, but the data suggests that not utilizing post-maneuver instructions is not necessary based upon our clinical practice guidelines currently. And so those are things that you can kind of think through on how you want to proceed in your practice. So looking at predicting success, the big things here are that in this study with 259 patients here in the middle, there's essentially all of these found no significant effect between sex, age, etiology, number of canal repositioning maneuvers, and short-term success or recurrent risk. Bilateral BPPV and atypical BPPV require greater numbers, and that would make sense. So atypical, I'm referring to horizontal or superior canal, the more rare BPPV presentations. And Nunez looked at 168 patients. The recurrent rate per year was about 15%, and then 50% recurrence rate at 40 months, and also found no association between the recurrence rate and the sex, age, duration of symptoms, and etiology as well. So just looking over our guideline flow chart again, we're just going to go over this quickly here. Let me get my laser pointer again. So a patient comes in with symptoms of BPPV. You differentiate that between that and other forms of vertigo. If you're still fairly sure or it sounds like BPPV, then you perform the Dix-Hallpike maneuver, the test. And if it's torsional upbeating nystagmus, then that would be consistent with posterior canal BPPV, which is the most common. If it's torsional downbeating nystagmus, beating towards the opposite side, so torsional towards the contralateral side, but downbeating, you would think about superior canal BPPV. And in that case, no imaging is recommended. I don't routinely get imaging. Vestibular testing is not recommended in these cases when it's clear cut. Medications are not routinely prescribed. A lot of these patients are already coming in being prescribed meclizine. Of course, we're going to educate the patient, assess for modifying factors. So if there are any contraindications to canal repositioning maneuvers, so some of our patients are going to have kyphosis or cervical immobility, which might lead us towards one positioning maneuver or another, or we may recommend vestibular therapy instead of trying to do the repositioning maneuvers ourselves. But if there's no contraindication, then perform the repositioning maneuver based on the type of BPPV. And they do not recommend post repositioning maneuver restrictions. And then reassess it 1 month, and then you can kind of either go back into if they're still present, or exit the guideline if it's clear. Of course, the supine roll test for lateral canal BPPV, and we talked about looking for characteristic direction changing nystagmus, and then performing the appropriate maneuver for those patients, depending on which side, whether it's geotropic, apogeotropic. So just a little bit about surgical treatment of BPPV. So this is a benign disease. It typically responds to repositioning maneuvers. However, surgical treatment may be necessary occasionally. And patients who have intractable cases or multiple recurrent cases, the surgery is effective and safe, but not without its risks. And so in these cases, the surgical treatment may be necessary or offered to certain patients. If you're thinking about surgical treatment, there are central lesions that can mimic BPPV, so imaging is recommended in these cases, especially if it's gotten to the point where it's so intractable and affecting these patients so significantly, or recurrent despite multiple physical therapy bouts and multiple repositioning maneuvers by yourself. It's probably a good idea to go ahead and get some imaging. I typically do. So the cingularectomy is mostly a historical procedure, I believe, for most people at this point. I've actually never seen one, but I've certainly read about it. It was popularized by Gasek in the 1970s, and it involves transection of the posterior ampullary nerve that runs in the cingular canal. And so it's approached with drilling inferior to the round window. And of course, we're close to the posterior semicircular canal ampulla and the vestibule. And so there's certainly a risk of severe vertigo and sensorineural hearing loss if those are injured. And Gasek just demonstrated initially 91% vertigo control, so quite good, but the risk was fairly high at 7.3%. Then published an update in 95 with a 3% sensorineural hearing loss risk. And this has overall just been replaced by posterior semicircular canal occlusion. And so in these cases, like we talked about, reserved for intractable cases. So if the symptoms are severe enough to affect their occupation or lifestyle, and they fail to respond to repeated maneuvers or vestibular therapy, and most of these patients are going to have vestibular therapy at this point before we even think about a surgical intervention. CTs can be useful in defining anatomy, the bony anatomy here as well. So this is, of course, approached via transmastoid route. And so you're going to identify your tegmen superiorly, your sigmoid sinus posteriorly, your antrum, enter your antrum, and your incus is identified here, horizontal semicircular canal. Of course, Donaldson's line defines essentially the spot just inferior to that is where your endosteo island or where your blue line should be. And so in this case, this is Brackman's text that describes making a little endosteal island here, drilling the posterior canal, blue lining it, then making a little island. That little bone chip comes off. And the most important part of this is you don't want to enter the membranous labyrinth. And so you can, once you've taken this little endosteal island off, you can wick away the perilymph and then decide what you want to pack it with. And so packing it can be done, and what's described here is using bone pate, fibrin glue. It makes a fairly solid plug, and you can plug it with that fibrin glue and bone pate mixture. Fascia is used as well, sometimes fascia, then covering it with some bone cement. In this case, fascia, the plug that they made, and then some temporalis fascia, and then coating that with the fibrin glue to prevent a perilymphatic fistula. There's also some variations that are described with utilizing the CO2 laser. That's an interesting approach. I've seen it at Michigan Ear Institute where they utilize the CO2 laser. It essentially lyses the membranous labyrinth and essentially occludes both ends of it, or it makes two ends on either side here. And then plugging proceeds with fascia or bone pate or bone wax or whatever you've decided to utilize. This is just a photo from Parnes' paper that shows a nice picture of the otoliths here. And I actually have seen this intraoperatively as well, and it's certainly interesting when you see that. But that's what at least it gives you confidence about what you're doing, and I hope that it's going to be effective, and it should be effective at that point if you see the otoliths like that. So patients are going to have typically going to be admitted. They're going to have 1 to 3 days of admission, maybe longer, but typically 1 to 3 days on average. Patients are almost universally going to have some disequilibrium or dizziness or motion sensitivity, and they recover well with physical therapy and vestibular therapy. So the outcomes have been reported, and they've shown safety and efficacy. Iral and Parnes looked at 44 occluded posterior canals in 42 patients. All of those years were relieved of BPPV. One did have a kind of a late atypical recurrence, and 40 had normal preoperative hearing. One had a 3-month sudden permanent profound loss, and then one had a mild loss. They also published a study regarding BPPV and superior canal dehiscence, where they found similar symptoms in terms of the plugging or the occluding of the posterior canal. 3 patients had permanent hearing loss. 1 was profound and 2 were mild. And the meta-analysis looking at including 8 studies that a total of 196 patients, and all of them had resolution of their BPPV symptoms. The total loss of hearing was about 1%, and loss of vestibular function was a bit higher at 9 out of the 68 recorded had some loss of vestibular function. And then there's also this report or this study about 6 patients who had bilateral posterior semicircular canal BPPV, and also was quite effective. This hearing was preserved in the majority of those patients. One patient had some mild hearing loss in the high frequencies, and the transient imbalance and disequilibrium occurred in all patients, and some still had some imbalance even long-term after with extreme head motion and residual instability mildly. But overall, their symptoms were controlled after the surgery. So it can be done in those cases as well. If you have bilateral posterior canal BPPV, of course, that would be a complicated situation and difficult to treat. However, would be an option. So conclusions, so BPPV, said that a lot today, treated effectively by the repositioning maneuvers, the Epley or the Semont maneuver in the vast majority of cases. The superior canal, of course, can be treated by the Epley, reverse Semont, deep Dix Hall Pike, and then horizontal canal BPPV, diagnosed with the supine head roll test, which we looked at. Keep in mind the geotropic, apogeotropic, and how to diagnose those. And they were treated effectively with the Limpert rotation, or the barbecue roll, the Gufoni maneuver, and the Vannucci maneuvers. And then posterior canal BPPV that doesn't respond to the classic repositioning maneuvers and vestibular therapy and physical therapy, the option of posterior canal occlusion is a safe and effective procedure. So I just want to acknowledge Dr. Sargent. Those videos that I used came from a lecture he gave, and I've used those with his permission. So I want to thank him for that. And here are my references. All right. Thank you for the opportunity to talk with you guys. I hope you got something out of it today. I appreciate it.
That was fantastic. Thank you so much.
My pleasure.
Usually open up the floor for questions. I've got some, but I'll hold them for now. So feel free to chime in. All right, I'll get some going. So there's some evidence to suggest that vitamin D deficiency might play a role in recurrent BPPV. Curious to know what your practices are in terms of testing for vitamin D deficiency, levels that you're looking for, and supplementation like guidelines or what you typically prescribe.
Yeah, only recently. So that was in my training, that was not something that we typically looked at. And so only recently, because the physical therapist that I've been working with here in Greeneville has brought it up, have I considered looking at vitamin D. So I haven't historically done that. So I really don't have what I'm looking for specifically, because I really haven't developed that yet. I'm still kind of developing that. But I'd be interested to hear if what you guys are looking for and if you're prescribing that yourself, because I haven't historically done that, but recently, after some discussions, I've thought about potentially doing that in these recurrent BPPV cases.
Yeah, we often will check for it. And I'm sorry, I can't actually remember what we prescribe. So, and I don't think Dr. Rizig is on the call right now. But something to look out for, and I think in the literature that I've reviewed, there is no like accepted number to look for and replacement therapy yet. But
yeah. I don't have those numbers in my head, but it'll be something that I hopefully look into and develop myself. So.
And then also curious to know when you get your physical therapy colleagues involved, at what point in the treatment algorithm, I think, based on the guidelines, try repositioning yourself? And then are you trying this multiple times, or are you referring right to physical therapy? What does that look like?
If it's if it's fairly straightforward, I typically will. So if it's fairly classic symptoms, they haven't been struggling with it very long, and they come in and the physical exam findings are consistent with posterior canal BPPV. I typically do the Epley maneuver myself and then see them back in 3 or 4 weeks. And if they're resolved, I don't do anything. If they're persistent, I typically do another maneuver at that time, then offer physical therapy for them. However, their nystagmus findings are, a bit more unclear, which certainly can happen, as we've seen. And then most of the time I'll say, okay, well, I'm going to give this a shot, but I'm going to go ahead and refer you to physical therapy in those cases, just to get the ball rolling. And if I'm able to treat it, great. But in those cases, I typically will refer, or in patients who have had it for a while, and some probably many times for you guys as well, when they've come to see me, a lot of times they've already had a course of physical therapy, and they've already been struggling with this for, they say a year off and on. And so those cases, I'll of course try myself, but get the physical therapist that kind of specializes that involved in those cases too.
Awesome. Makes sense. Well, Dr. Wilkerson, it was a pleasure. Thank you so much again for giving us this lecture. It was fantastic.
Thanks so much. I appreciate it.
All right. Take care.